that should be better. But thanks very much for that introduction. So my name's Matthew Lowry, I'm a clinical fellow at the University of Edinburgh, and I'm going to talk about the influence of age in the diagnosis of acute myocardial infarction. Is it possible to have the slides up, please? Okay. So the 99th centile is used as the diagnostic threshold for myocardial infarction, and it's derived in a cohort of healthy individuals. However, the age of this cohort can influence the 99th centile, and we frequently observe older patients without myocardial infarction who have a troponin level above this reference value. Using a reference value derived in a younger patient population may therefore incorrectly diagnose myocardial infarction in older patients, resulting in inappropriate treatment and potential harm. So our aims were to assess the performance of cardiac troponin to identify type 1 myocardial infarction in older patients using the 99th centile, compare this against the performance when using age-adjusted thresholds and universal thresholds above the 99th centile, as both of these have been proposed as means of improving specificity of troponin testing, and then finally to assess what impact cardiovascular comorbidities may have on this performance. To do this, we conducted a secondary analysis of the high sensitivity troponin in the evaluation of patients with suspected acute coronary syndrome randomized controlled trial. And I think the important thing to know about this trial is that it had a consecutive recruitment of patients with suspected acute coronary syndrome, meaning a large and representative patient group was recruited. And all cases of myocardial injury were adjudicated according to the fourth universal definition of myocardial infarction, allowing us to use our desired endpoint of type 1 myocardial infarction. The trial used an Abbott Arctic Stats high-sensitive cardiac troponin I assay, and you can see the age-adjusted and universal thresholds in the graph. The age-adjusted thresholds were derived in a general population study, including about 19,501 patients, and the universal threshold was taken from the ESC guidelines. The two outcomes of interest we're looking for were the diagnostic performance of presentation troponin, which we're going to measure using sensitivity, specificity, and positive predictive value calculated using a confusion matrix with bootstrapping, and to assess cardiovascular comorbidities, we used logistic regression. So this is a table showing the patient demographics in the trial. For this subgroup analysis, or secondary analysis, we included 46,444 patients who age ranged from 18 to 108. If we focus on the older group of patients, those who are 75 years or older, we can see that compared to younger patients, they're predominantly female. They're less likely to present with chest pain. As expected, cardiovascular comorbidities are more common. Also less likely to have ischemia on a 12-lead ECG. And we can see that the percentage of any form of myocardial injury, and particularly type 1 myocardial infarction, is increased with age. This graph shows the distribution of patients in the study, and those patients who have at least one troponin above the 99th centile are coloured in blue. And I think what's most striking about this is you can see the majority of patients who were suspected of acute coronary syndrome had negative troponin measurements. But I also hope you can appreciate that the proportion of those with myocardial injury also increases with age, to the point that patients who are 90 years or over, more than 50% of them had some form of myocardial injury. This graph below shows the adjudicated diagnosis according to the fourth universal definition as a proportion of those patients with myocardial injury. And here you can see that type 1 myocardial infarction, which is in red, as a proportion of the cause of any cause of myocardial injury, actually decreases with increasing age as other forms of myocardial injury, acute myocardial injury, type 2 myocardial infarction increase. Looking at the specificity across age, this is a line of best fits graph, and you can see that the 99th centile is represented in red, age-adjusted thresholds in the orange dashed line, and the uniform rule-in thresholds in blue. And we can see that overall specificity decreases with increasing age, with the universal threshold achieving the high specificity across the three thresholds tested. If we look at the positive predictive value, we can see this rise and fall, which is very similar to the proportional bar charts that we viewed in the previous slide. Here we can also see that the positive predictive value decreases with increasing age. Again, the universal threshold performs best amongst these three thresholds, But it's still important to recognize that, patients who are 75 years old with a positive predictive value is still less than 50% for all of these. Looking at the sensitivity, this was not changed across age groups, but was more in line with the degree of increase in each threshold above the 99th centile, as we'd expect. This table shows the output of the logistic regression modeling. I think it's best just to focus on this top line. So the two models, the baseline model had as its dependent cardiac troponin above the 99th centile, and its explanatory variable as a any troponin above the 99th centile. Sorry, the dependent was type 1 myocardial infarction. And the comorbidity adjusted model added in the comorbidities that you can see on the left. And although we can see that the odds ratio decreases as we go across age groups, there's no difference in the odds between the two models. And we conclude that the comorbidities that were included in this model didn't change the association of a raised cardiac troponin and type 1 myocardial infarction. So in conclusion, age has a significant impact on the rule-in of type 1 myocardial infarction. The universal threshold performed best, however, there was at the cost of reduced sensitivity. And in our cohort, 1 in 2 patients who are 75 years or over with a presentation cardiac troponin above the threshold ultimately did not have a diagnosis of type 1 myocardial infarction. And my takeaway message would really be that in older patients, clinicians should consider carefully the rule-in of type 1 myocardial infarction on the basis of a presentation cardiac troponin sample only. So thank you very much for your attention. I'd like to welcome any questions.
Thanks, Matthew. Very important work. Are there questions from the audience? Salvatore?
Can you hear me? Yeah.
Yes.
Congratulations, Matthew. A really great job. I'm wondering which is really the value of each comorbidities, because you put there cardiovascular disease. I think that atrial fibrillation should be considered as one of the top of criteria, because like we saw on the presentation on NT-proBNP, able to detect outside heart failure some other comorbidities. Why not to use in these patients the use that I really like very much, the concept that we are going to take careful decision-making in these elderly patients aged greater than 75. How much is the role of each one? Which is how much atrial fibrillation that I was not looked there that you have in your patients?
Yeah, thanks very much for your question. I think you're absolutely right. There's lots of comorbidities that weren't included that will be important and affect the performance of these investigations. And I guess I'd also like to start by saying we are limited to some degree in the data that we're using in this study. The comorbidity data was collected using an electronic health records. We didn't have an objective measure of much of these comorbidities, for example, BNPs, like biomarkers or echocardiography. And we also know that as well as cardiovascular comorbidities, there are non-cardiovascular comorbidities that can result in elevated troponin samples, such as chronic obstructive pulmonary disease. So I think the role of comorbidities is not quite fully answered there. And I think that really a more extensive study, we have these more objective markers of disease severity would be required to do that.
So one possible suggestion for you as a next step on, to provide really, the help for clinicians. The cutoffs that you have tested, most of them were derived for the ruling of myocardial infarction as kind of all types, including type 1 and type 2. And so I think it would help to see whether in your cohort, if you combine type 1 and type 2, you get to similar positive predictive value than the previous work. And if that's the case, then I think the lesson would be the cutoffs work. But particularly in elderly patients, if you have a clear trigger for type 2, like if you have atrial fibrillation with a rapid ventricular response, then of course your message would be, of course, do not bring the patient to the cath lab, but consider type 2 as possibly the main mechanism, acknowledging that, of course, many of these patients then have limited workup to be very sure whether it's type 1 or type 2, but that is just a suggestion of how to make additional use of this fantastic data set that you have.
Yeah, thanks very much. In subgroup analysis, we did recalculate the parameters with a combined endpoint of type 1 and type 2 myocardial infarction. And we can see that it results in an overall improvement of specificity and positive predictive value compared to just using type 1. But we still see the decline in these parameters with increasing age.
Well, I have the urge to ask one question too. What about how are we going to improve the diagnosis of myocardial infarction in older patients who don't present with typical chest pain?
Yeah, I think that's very, very difficult. I guess that that kind of falls partly down onto your clinical acumen. I think, one thing I would also say is that I think it's better to think about troponin not as a kind of binary decision-making tool. Maybe perhaps as it is widely used, and to think about it more as a piece of the puzzle or adding to the probability of what the diagnosis might be and whether that could be type 1 myocardial infarction. So I think it's really about considering the whole picture of the patient, and as opposed to saying if this is positive, this is ruled in. It's thinking about, well, what's the probability of that?
Thank you very much.
Okay, thank you.